Friends, let's talk about thoracolumbar fractures and the management today. We are even going to cover the classifications in details because they may be asked you in parts in your theory examination. Now, the thoracolumbar fractures may range from undisplaced fractures to complex fracture dislocations. Anatomically, they may be either in thoracic spine, in lumbar spine, or at the thoracolumbar junction. Now, out of the total fractures, 25 to 40% are in thoracic spine, 50 to 60% are in thoracolumbar junction, and 10 to 14 are located in lumbar spine. The thoracolumbar junction is the most common site of these injuries. Why is it so? Thoracic spine in general as compared to lumbar spine is rigid. This rigidity is because of the coronally oriented facet joints, the disc spaces which are thinner, and the association and articulation with the rib cage. Now, these coronally oriented facet joints are different from the ones in cervical spine. The facet joints in cervical spine are sagittally oriented. This is the reason why we get dislocations of facets in cervical spine, but we don't see dislocations of facets in thoracic spine, but we see fractures. Now, along with this, the capsule of facetal joints in cervical spine is loose as compared to that in thoracic spine, which is tighter. So, because of the alignment of the facets and the capsule, we see dislocation of facets in cervical spine, which is not an occurrence in thoracic spine. Now, the spinal column in the thoracic area is narrower. This is the reason why any injuries in thoracic spine definitely most probably cause spinal cord damage. The injuries that happen in lumbar spine on comparison may not incur spinal cord damage to that extent what may happen in thoracic spine. The lumbar spine on comparison is flexible. This is owing to the thicker disc space, the sagittal orientation of facet joints, and the absence of rib cage. This is what gives some mobility to the lumbar spine, which is not present in thoracic spine. Now, along with this, neurological deficits are primarily of less incidence because of large neural canal in comparison to thoracic spine, and there is greater resilience of the cauda equina nerve roots. That means they can possibly escape some injury as compared to the caudal area in the thoracic spine. Why is thoracolumbar junction commonest out of the three? Now, firstly, it is the zone of transition between the rigid and kyphotic thoracic spine, which is stable as we discussed, and the mobile lordotic and relatively stable lumbar spine. This is the reason why this is more susceptible to injury. As we see here, this is the zone of transition, and most commonly injuries occur here. What is the incidence? These injuries are more common in men. The incidence is between 20 to 40 years of age. The mechanism of injury may either be motor vehicular accidents or fall from height. Now, whenever there is a history of fall from height, you have to look out for associated injuries, especially calcaneum fractures. Because when the patients land up on their feet, in such case they will incur calcaneum fractures, and the axial transmission of load that occurs through the spine will cause fractures in these areas. These fractures are associated with complete neurological injuries in 20% of the cases, incomplete in 15% of the cases, and there is an association of other injuries in more than 50. On examination, we have to look out for the history. the local examination, because we will get an idea of the deformity, and so the region of exact fracture just on examination, the neurological evaluation, and the ASIA grading. Now this ASIA grading is important. This is the grading that was given by International Society of Spinal Cord Injury. They have a very vigorous system of examination. This is the chart that has to be filled and followed. So let's talk about ASIA classification. Now ASIA classification, or the American Spinal Injury Association, was given by International Spinal Cord Society. Now they have divided the entire classification into motor and sensory parts. Motor scoring is as per the grading that we do. The sensory can be divided into pinprick and light touch. The key muscles that are defined by them are elbow flexors C5, wrist extensors C6, elbow extensors C7, finger flexors C8, and finger abductors T1. Along with this, when we talk about lower limbs, hip flexors L2, knee extensors L3, ankle dorsiflexion L4, lower toe or the long toe extensors L5, ankle plantar flexors S1. Now the total scoring that would be possible is 25 plus 25 on either side, that is 50. As per the muscle grading that we do, each muscle can be graded from 0 to 5. 5 is the maximum. There are 5 myotomes in upper limbs and 5 in lower limbs. So if ever the patient is having the maximum power, 5 into 5 will be 25 on the right side and 25 on the left side. This is what is denoted here. The maximum scoring for upper limbs will be 50. Similarly, there are 5 myotomes in lower limbs. So 5 into 5 on either side will be 25 on the left and 25 on the right. And the maximum possible scoring is 50. This is how the total muscle scoring would be 100. When we talk about the sensory examination, we have to check for the sensory examination in all the dermatomes as shown in the figure here. Now, this is divided into absence of sensation completely, which is score 0, altered sensation is score 1, and normal sensation is score 2. The maximum score would be 112, which has to be calculated independently for pinprick and light touch. So the total comes to 224. Along with this, the important thing that is to be seen as per the ASIA impairment scale or the ASIA grading is deep anal pressure. That is, we will have to look out for the contraction of the anal sphincter. According to this, the ASIA impairment scale is given, which may be from A to E, in which A is complete injury, B is incomplete, that is, there would be some motor or sensory levels intact below the injured level. For example, if ever the patient is having an injury at DA D10 level and the muscles in L2, L3, L4 dermatome are intact, it will be classified into Asia B. Asia C is motor power intact in myotomes but less than grade 3. This will be non-usable muscle power. Asia D is usable muscle power more than grade 3, and Asia E is completely intact or no deficit. If the patient is having some sensory involvement, even subtle, he will be classified into D and not E. How do we diagnose these?
Thank you, sir. So thank you for the excellent talk as always. So if there is no any other doubt, I think with the permission we can call it the day, sir.
Sure thing.
Thank you, sir, and good evening, good night, bye.
Good night, bye.